Hello, welcome everyone to this webinar series exploring gross examination and frozen section. This is the first webinar in the four-part series, and today's webinar is titled Gross Examination and Frozen Section of the Head and Neck Pathology and Oncology Surgical Specimen. My name is Dr. Kedar Deodar. I'm a professor at Tata Memorial Hospital, Mumbai, and I'm the regional Royal College of Pathologists, International Regional Advisor for the Southeast Asia region. I've created this program with the help of Mr. Giles Henrati, who's the Royal College's International Education Officer, and I'll be moderating this program. We have been guided by Professor Martha Cohen, who's a VP of the Learning of the Royal College of Pathologists. Coming to the agenda, we will have a small series overview as to inform everybody what is planned. Then we'll have a lecture by Dr. Asavari Patil, which was about 60 to 75 minutes. And then we'll take questions for 15 to 20 minutes in the Q&A sessions. And I will encourage all the participants to mention those questions in the Q&A sessions. It's not a hard and fast landing, but we'll try to give time to questions as well after Dr. Asavari Patil's lecture. So coming to the overview, we have planned 4 lectures. These are web lectures, and as I mentioned today, we have on the 5th February, we have gross examination and frozen section of head and neck pathology, oncology, surgical specimens. On the next Wednesday, 13:30 time, it's a frozen section of 13:30 Greenwich Mean Time, frozen section and breast pathology of the pathology, surgical oncology specimens. And the following Wednesday, 19th February, we have frozen section and gynecological pathology and oncology specimens. And the 4th lecture, which is the last lecture, which is a gross examination of colorectal carcinoma specimen, which is on the 26th of February. Below is this is the last line is actually the link, which is to college's reference web page where the webinars are advertised. You're welcome to take a picture at the moment or write it down so that you can register for the next webinar. Please bear in mind, and each webinar you'll be needing to register individually. This is actually on the Royal College of Pathologists website, and this is a logo, GEFS. This is where on the college's website, we have gross examination frozen section webinar series, and this indicates the event this is a part of the series. To introduce our speaker, Dr. Asavari Patil is actually a professor and at Tata Memorial Center and Tata Memorial Hospital. She has a vast experience over 30 years, and she's our colleague who works in our department. She has experience in breast cancer pathology as well as head neck cancer pathology, and she has more than 50 publications in a peer-reviewed journal. And she's also member of the editorial review board for head and neck pathology specimen. So it is a pleasure to invite Dr. Asavari Patil for this webinar. We couldn't find a better person for this. The idea of selecting this time is that it is probably we thought it is convenient for Southeast Asia region postgraduate students or any pathologist or interested people. However, all the participants from any part of the world are most welcome for this series. So let us hand it over to Dr. Asavari Patil.
Okay. Thank you, Dr. Kedar. I must thank Royal College of Pathologists, especially Mr. Giles Henrati and also Dr. Kedar Deodar for giving this opportunity to share our experience as well as sharing the guidelines for crossing head and neck pathology specimen. This is going to be almost an hour lecture, and let me start sharing my screen. I hope everybody can see my screen.
Yes, I can see your screen. You can make it full page, please.
Yeah, I did that.
Yes. Okay.
Okay. So first of all, we are going to cover most important organs in head and neck region. These are my disclaimers. This is mainly teaching purpose. Presentation is for teaching purposes, and we do have some figures from textbooks or from I've got it from online. So let's start with the overview. What are we going to cover today in this webinar? First of all, I'm going to discuss principles of grossing head and neck specimen, so which will be followed by brief discussion on anatomy and grossing techniques in four major subsites in head and neck. One is going to be oral cavity, second is going to be nasal cavity and paranasal sinuses, then larynx, and lastly lymph node dissection. Then we'll have a discussion on frozen section, how it is useful for head and neck specimen, and I'll discuss cancer data sets, their importance, and what are the cancer data sets for different subsites in head and neck before we end this webinar. So what are the principles? So we need to understand that what, as a pathologist, what is our role when we get a big excised tumor specimen, or what we call it as radical surgery or wide local excision. So as a pathologist, we are supposed to provide a key information to the oncologist regarding the tumor classification, pathologic tumor and nodal stage, the prognostic data, and also whether it is completely excised with enough adequate margins or not. So a structural pathology report is very important for the oncologist, surgical as well as medical and radiation oncologist, to plan further treatment for cancer patients, such as what type of adjuvant therapy, if at all it is required. Also, it is this information is necessary for prognostication in those patients, and thus a structured pathology report can provide a high standard of care to the cancer patients. So what is a structured pathology report, or what we call it as synoptic report? So they are based on the cancer data sets, which are actually structured collection of data related to the specific cancer. They define the best practices in handling, reporting cancer specimens. They are evidence-based and comply with international standards and enable pathologists to provide a standardized report. It's like a checklist for the pathologist, so that pathologist can include all important parameters that are essential for further treatment decision. Now, coming to head and neck cancer specimens, there are particular challenges why when we are grossing head and neck cancer specimens, because head and neck includes multiple anatomic sites, and the three-dimensional anatomy is quite complex. There are many vital structures which are adjacent to those subsites, like nasal and paranasal sinuses. They are adjacent to the skull base and orbit. Also for larynx, again, they are adjacent to other major vessels in the neck. So orientation of this specimen can be difficult, because you have to understand, for a surgical oncologist, especially the head and neck surgeon, when they are dissecting the tumor with adequate margins, they do not have much room for adequate margin. They have to get margin which is just enough. Having too much of margin is going to lead to morbidity for that patient. So they will try to get adequate margin, not too much of margin, and they will, whatever the specimen you receive, many times it may be difficult to orient unless it is oriented by the surgeon. Now, once we orient the specimen, assessment of tumor with its relation to vital organ is again difficult sometimes. We have to identify all the margins in head and neck cancer specimen and measure the accurate distance from the tumor. And all this information, accurate assessment, crossing, that needs knowledge of head and neck surgical anatomy. We need to know what type of surgical procedure is performed and what specimen is there on our grossing table. And we need to know what are the clinical and radiological findings, especially for tumors like paranasal sinuses. We need to know exactly where the tumor is located and what are the structures it is invading. So what are the objectives of grossing any cancer specimen? One is to assess tumor stage, that is tumor size and tumor extent. Second is to assess the margins with respect to the tumor, whether they are free, close, or involved. And then what we do is, after recording all this data, we sample representative tumor tissue, margins, adjacent tissue, and we evaluate it microscopically and collect the data and put it together for synoptic reporting. And these elements or these parameters are all listed in cancer data sets for particular organ. Now, the key principles in grossing cancer specimen is First is you identify the specimens received and verify the information on the request form. So now, first and foremost is the request form is the most important thing, which will see what it should include. Now, once you identify and verify the information, then orient the specimen, which is followed by a meticulous gross examination, which includes we should enumerate all the specimen components, whatever the measurements are. Most of the times is three-dimensional measurement we have to document. Then you identify the tumor, again take the measurements, document its location, where exactly it is located, if there are any other structures it is invading. For example, if it is a tumor in buccal mucosa, whether it is going to the alveolus or not, and so on. Again, we identify the mucosal, soft tissue, and bony margins, document the distance, and then that is followed by inking the inking of the specimen. Once you ink the specimen, we submit. This is a kind of overview of all grossing specimen of all sorry, grossing for all specimen. So once you ink the specimen, submit the margin, submit the tumor, adjacent tissue, including bone and skin, and all this is going for processing, which will microscopically evaluate it. So first and foremost important thing is request form. What should it include? It should include all patient identifiers, name of the patient, hospital case number, age, gender of the patient, also our pathology accession number, and clinical information should include type of surgical procedure. The request form should have a list of all specimens separately sent, because most of the times when you get a radical surgery specimen, it is not a single specimen. You will have a primary specimen, which is the surgery primary excision of tumor. With this, you may get some revised margins, sometimes some adjacent organs, and many times we get lymph nodes and the neck nodes, if they are included. They could be at some surgeons send it at different levels. You will get different levels separately. So everything we have to code, we have to just verify what the specimen we have received, and it is all listed in the request form. Then laterality and orientation of the specimen is very important, especially those specimen like wide local excision, because otherwise we will not be able to identify what are the margins. Then relevant radiological findings, if they provide, it's very good. And then what we require is history of any prior surgery, any neoadjuvant chemotherapy or radiotherapy. Now, why it is important? So if there is any prior surgery, suppose a patient has undergone some wide local excision of buccal mucosa or maybe segmental mandibulectomy, so that definitely alters the anatomy of that region. So subsequent specimen, if there is a recurrence and after a few years we get another another excision specimen, that time understanding the anatomy of that specimen and relevant margins can be difficult. So if you have a prior history of surgery and that is given to you, then you can always discuss with the surgeon and find out what are the margins that are relevant for that particular specimen. Again, same is true for neoadjuvant chemotherapy or prior history of radiotherapy, because many times the tumor may get it may respond to the chemotherapy, and when you are crossing it, you may not be able to find exact tumor. All that we can see is sometimes a puckered mucosa or some induration. So if we know that this is a post-neoadjuvant therapy or post-radiotherapy specimen, we can identify those areas, submit entire the area and adjacent tissues, so to make sure that we are not missing any residual viable tumor, and we make sure that the tumor bed, maximum tumor bed is included in our sections. Now, if there is any frozen section done, those details should be available at the time of grossing, because those who are doing frozen section, all of you know that any tissue which is submitted for frozen section, the rest of the tissue is again processed and processed for paraffin embedded tissue. So when we say request form, this is what we see. This is from ICCR request form. Usually what you have is a patient's name, date of birth, patient identifiers, date of request, when was the surgery done, and when was the request form generated, laboratory numbers, and then you have clinical information and specimen submitted. So something like that, you have to have the request form, and one has to make sure that you have to be always contacting your surgeon to make sure that you get all the information while you start the grossing. So what are the steps? Again, this is a overview of the steps. We are going to go through each and every specimen separately again. So when you receive the specimen, you have checked all the identifiers and everything. What we have to do is orient the specimen first, right side, left side, which is the superior side, which is the inferior side, and so on. Identify all components. Suppose it says composite specimen, which has hemimandibulectomy and buccal mucosa. Identify all the components. Then check the clinical and radiological findings if available to understand the tumor site and extent of tumor. First, identify tumor, identify the margins, document the size of tumor and extent of tumor. Margins also you have to document the distance of the margins from the tumor. Then ink the specimen and first you start submitting the margins as far as possible. Slice the specimen. Now, when we actually document the measurements of the tumor, we can take two dimensions before cutting it, but as you slice the specimen, the third dimension, that is thickness of tumor, can be measured that time. Now, after all this, we submit the tumor sections, adjacent organs, margins already submitted. If there are other structures included like bone, then you have to cut the bone. Now here, bone cutter is essential. A laboratory that is going to process head and neck specimen, we have to have a bone cutter in the grossing room because many times you get mandibulectomy or maxillectomy in a composite resection specimen. We have to cut the bone to see whether the bone is involved or not. So underlying bone has to be checked for any tumor involvement and submit those sections. Even if it is not involved, adjacent bone, the portion of bone closest to the tumor has to be submitted. Same is true for skin. Skin, if it is involved, submit the sections. If it is not involved, document the distance of skin from the tumor and submit the closest skin surface. Then there are any adjacent organs included. Suppose you have, sometimes there could be a composite specimen which includes portion of tongue also, because the tumor is probably reaching the floor of mouth and they may take out, or otherwise, if it is a tongue specimen, they may have some mandibulectomy with that because the tumor is also involving floor of mouth going close to the mandible. So in that case, all adjacent organs we have to identify. If it is a larynx specimen, we have to identify if is there any thyroid lobe and is it involved or not, and so on. So these organs, once you identify, look for tumor involvement. If it is involved, take section. Even if it is not involved, we have to take this representative section of adjacent organs, and all these sections are submitted for processing. And then rest of the separately sent tissues, it could be revised margin. Sometimes they can send um, a nerve, portion of nerve to look for any tumor is in, if it is involved by any tumor. So whatever the separately sent tissues, including all lymph nodes, they are all submitted separately. And what is important is to have a key of the blocks or section key. So it should specify, it's not mandatory, but it's good to have always a section key which can specify what are the tumor sections. Like 1 to 4 can be tumor sections. Now, number 5, block number 5 can be some margins and so on. So if that section key is there, anyone who is looking at the microscopy can identify exactly from where the section is coming from. This is especially true for big hospitals or big laboratories when the person who is grossing the specimen may not be there while the case is being signed out. So section key is very important in that case. Now let's come to the margins of specimen. Now in case of head and neck margin, specimen, understanding the margins and submitting the correct margins is very important. As I told you, there may not be too much of margin available. So it's our duty to document the exact distance of margin, the closest margins we have to identify and submit all the relevant margins. So what are the relevant margins? When it comes to the any mucosa containing tissue, it is mucosal margins are very important. Now, in addition to mucosal margins, there could be some soft tissue margins. Like if you have a specimen of buccal mucosa and skin is not removed, then lateral soft tissue margin, or sometimes they will call base. So that margin will be important. Now, if the specimen contains lip, then mucocutaneous margins are important. The mucocutaneous margins, will see how they are submitted. Usually they are shaved, but if they are close to the tumor, then we have to submit radial. When it is nasal cavity specimen or maxilla is included in the specimen, we need to submit antral mucosal margin as well, or antral margins. Larynx, again, it has set of margins of its own, which we'll see when we discuss laryngectomy specimen. When bone is included, bony cut margins we have to identify depending upon the type of the specimen and as they submit the bony cut margins. And there are many other margins depending on the type of specimen. Suppose we have total maxillectomy with orbital exenteration, then optic nerve cut margin has to be submitted. Sometimes nasal septum is included, nasal septal margin has to be submitted. Inferior tracheal margin, if it is laryngectomy specimen, we have to submit inferior tracheal margin. So let's understand how the margins are submitted in the head and neck specimen. So here, all of us, we need to know what are radial margins and shaved margins. This is true for all cancer specimen, not only for head and neck. So a radial margin is taken perpendicular to the cut surface. Okay. So if you see in this in this figure, the top left hand side, we have a specimen wide local excision with a tumor on that, and there is this cut surface here, which is inked. That measurements are taken and ink, the cut surface is inked. Now, if you submit the margin perpendicular to the inked surface, that is radial margin. And if you shave the margin, it is like peeling off the skin of an orange. So that would be a shaved margin. So in the last and the right hand side and bottom diagram, you can see there is this radial margin, the way we cut. I would say if you cut, the type of cut would be the way we cut a pizza, or that kind of perpendicular cut has to be there, and the radial margin is seen. What is the importance of radial margin? It can show you both tumor and the cut margin, and we can identify the exact distance of the margin from the tumor. Now, shaved margin, on the other hand, we are just taking the shaved inked surface. Now, here we have to completely rely on gross documentation of margin. So clearly, whenever we are looking at any case and the margins are close, if possible, we try to submit radial margins to make sure that we can document exact distance of the tumor from the cut margin. So I hope you have understood all the concept of radial and shaved margin. So how the margins are sampled in head and neck specimen? All mucosal margins are submitted radially. Now, when it comes to the mucocutaneous margin, is in for when the lip is included, they are almost always shaved to include most of this area. But sometimes the tumor can be close to the margin. In that case, the closest mucosal or skin cut margin we have to give separately. Now, if there are soft tissue margins, like you have lateral soft tissue margin for buccal mucosa when skin is not included, that has to be submitted radially. All bony margins, most of them are shaved. So documentation of distance is important. Bony margins are submitted as shaved margin and submitted entirely. And then if we are dealing with a laryngectomy specimen, inferior tracheal margin. Now here again the same principle applies. If it is very close, which usually doesn't happen, they take enough of margin. If it is close, then and then only submit radial margin. But most of the times there is adequate margin provided, and we can submit a ring. The shaved margin can be easily submitted. So in this photographs, you can see on the left hand side and top, you have one wide local excision specimen, which is oriented with the sutures. Okay. And you can see this is the tumor and there is this mucosa, and the way the scalpel is placed. This is the radial margin. Okay. This is another specimen. When we take two parallel sections, the radial margin will be, we can cut the radial margin. And when you submit the radial margin, you can see that there is on one side, there is ink, which is the margin. On one side, there should be mucosa and the rest of the tissue. So clearly, you should be able to see mucosa and ink portion and the rest of the tissue, which shows where exactly the tumor is. So let's come to each type of specimen one by one. If this is a hemimandibulectomy specimen, a composite resection with part of buccal mucosa. So you can see this is the medial view. There is this mucosa here, and the margin, mucosal margin is submitted radially. But then we have this mandible here, which should be shaved. Now, what type of space section, what are the sections to be submitted once we finish our documentation of grossing? We need representative sections of tumor, at least 3 to 4. Now, when you submit the tumor section, please try to include adjacent mucosa. That is most important thing. We'll see why it is important, but adjacent mucosa is essential when we are looking at depth of invasion, when we want to measure the depth of invasion. So tumor sections, if it is a big tumor or if it is post NSCT or neoadjuvant chemotherapy, we can submit. If it is a bigger tumor or if we see you think that you cannot accommodate the or put entire tumor with all depth of invasion in one cassette, we can always divide. We can take it in a grid form. You can always divide in two parts and make a diagram. That top portion is from near the mucosa. The the second portion is in another cassette which is closer to the bone and so on. Again, we submit all margins and the specific margins, bone, skin. If there are any other tissues included, for example, if there is orbital exenteration, then we have to submit sections from eyeball. If it is laryngectomy, we have to submit sections from thyroid lobe and so on. Now, there could be separately sent margins. Sometimes they send infratemporal tissue that has to be sections as the documented and submitted. Now, coming to the surgical anatomy and types of specimen in head and neck. So, this is a brief overview. We can see that there is this oral cavity which contains tongue, buccal mucosa. Then there is nasal cavity, paranasal sinuses, and then pharynx, which is nasopharynx, oropharynx, hypopharynx, and then there is larynx. So, first of all, the oral cavity, to understand the anatomy of oral cavity, we need to know what are the parts of the oral cavity. So, oral tongue, which is anterior two-third of tongue, then the upper jaw, lower jaw, we have floor of mouth, then buccal mucosa, retromolar trigon is the posterior most portion, which is closer to tonsil. Palate, you can see hard palate and soft palate, lips, upper lip and lower lip. Now, when you see the gingiva and the buccal mucosa, so there is this gingivo-buccal sulcus on each side. One is superior, one is inferior. And as you see the lips, there is gingivo-labial sulcus, which is superior, upper and lower, gingivo-labial sulcus. So identifying all these structures is important to know where exactly the tumor is located. So what are the types of oral cavity specimen we see? For tongue, we can have wide local excision or partial glossectomy. It can be hemiglossectomy, near total glossectomy. For buccal mucosa, there is wide local excision, white resection, composite resection. Lip can be again wide local excision and composite resection. Palate again, wide local excision, composite resection. So what are these specimen? What is composite resection? When we are saying composite resection, it usually includes multiple anatomic sites and usually one of them is bone, and most common is jaw bones. Amongst that, it is mandibulectomy is more common, and mandibulectomy with adjacent organs. So it can have buccal mucosa, it can have lip, tongue. Sometimes, if it is maxillectomy, then that will include upper alveolus, palate, and buccal mucosa. So mandibulectomy, there are different types of mandibulectomies: hemimandibulectomy, extended hemimandibulectomy, segmental, marginal, and so on. Maxillectomy, we are going to discuss that in the next section. And then bite composite resection. So bite composite resection is usually a specimen which is usually done. This type of surgical procedure is done for larger tumors, especially when they are involving buccal mucosa and retromoral trigon, which is quite common in Indian population. And this usually includes buccal mucosa, part of mandible, and part of maxilla. So what are the types of glossectomy? As we discussed earlier, this is first one on the left-hand side, which is shown in blue color is partial glossectomy, can be part of tongue. Then hemiglossectomy, it is the anterior two-third half of the tongue. Near total glossectomy includes majority of the tongue, although some posterior part is retained in the or spared, while total glossectomy is entire tongue is removed, which is usually not a very common specimen done for only very big tumors. Now let's look at the types of mandibulectomy. This is marginal mandibulectomy. What is marginal mandibulectomy? When the tumor is kind of abutting the mandible, but we know that is probably not involving, and the surgeon wants to preserve the mandible. So in that case, portion of mandible, which is the, as you see here in this box, the that portion only is removed and rest of the mandible is kept intact so that it will not lead to too much of morbidity for the patient, and patient may not need further reconstruction surgery. So this is marginal mandibulectomy. Now here we need to understand, when the marginal mandibulectomy, when this we get this kind of specimen, there are three margins, bony cut margins we need to have. Is one is anterior on the left hand side, posterior on the right hand side, and inferior below. All of them are denoted by red arrows in this diagram. Then there can be a segmental mandibulectomy, which is removal of full thickness of mandible. Now, segmental mandibulectomy can be any of the segment of mandible. So it could be a portion in the uh, portion of the mandible like this. It may be posterior segmental mandibulectomy, which includes entire portion of this mandible, including this posterior part, and not going up to anterior middle portions. That is not a hemimandibulectomy. It is less than that, but posterior segmental mandibulectomy may include the posterior part of the mandible. Then, if you see this posterior segmental mandibulectomy, you can see that this entire piece of mandible is removed. So we have two bony cut margins. There is one anterior and there is posterior bony cut margin. All of these are submitted shaved margin. Now, again, segmental mandibulectomy, when it includes the middle third or anterior middle third of mandible, as we see in this diagram. So then we have this two bony cut margin again shaved, but that will be a right lateral bony cut margin and left lateral bony cut margin. So we have to understand what are the cut surface of mandible is, what is the cut surface of mandible is, and how to submit that. And lastly is this hemimandibulectomy, where you have part of half of the mandible is included. So here there is only one cut surface, which is anterior bony cut margin. So I hope I have made this margins of mandible easier. Now let's look at the wide local excision specimen, how the margins are submitted, mucosal margins. So here, most important here is orientation of the specimen. First, before you cut the specimen, if you don't have any orientation, call your surgeon, ask them how to orient it, which is the superior or portion, which is the anterior, posterior, or inferior, or medial, or lateral portion. If you don't know that, then we cannot submit the margins. We don't know which margin is what, right? So here, most of the times there are threads attached, and the surgeon will specify on the request form which thread is for what. So sometimes they may say that the small thread is anteriorly, long thread is laterally or superiorly, and so on. So once you identify the threads, orient it, ink the margins. Here you can see there is this tumor, the stitches are there, and the mucosal margins, there are usually four mucosal margins when we get a wide local excision specimen. Same is true for hemiglossectomy. If we have this hemiglossectomy, then there is usually anteriorly stitches attached. You can identify the tip of tongue. There is this tumor you can see here. So there is this lateral mucosal margin, medial mucosal margin, posterior mucosal margin. There will be anterior-inferior mucosal margin. And then for tongue, it is always important to find out the base. Base is the, when you slice the specimen, which is the deepest portion of the tumor, and the distance of the tumor from the base of the specimen. Again, the base is also inked. You document the distance and submit the base separately. So for wide local excision, and when it is not including any skin, and for hemiglossectomy or any partial glossectomy, we have four mucosal margins, that is, and there will be one soft tissue margin, which is base of the specimen. Sorry. So coming to the hemimandibulectomy specimen. Now this is a composite resection specimen with buccal mucosa and hemimandibulectomy. You can see this is the medial portion of the mandible, you can identify the tumor which is involving the buccal mucosa. Now there is this lateral mucosal margin, anterior mucosal margin, medial mucosal margin, and posterior mucosal margin. And the bony cut margin is going to be the anterior bony cut margin of mandible. Now this is a bite composite resection. We can't see the tumor here, but at least we can see the um, margins, all of the margins. Okay. So you can see this is again medial view of bite composite resection. There is little bit of skin on the lateral side. This is the lower alveolus. This is upper alveolus. The margins are inked. Now you can see that anterior mandibular cut margin is there. Now, for bony cut margins of upper alveolus or palate, we can't show it in this diagram. We'll see it later. Superior mucosal cut margin you can identify. There is posterior mucosal cut margin, inferior mucosal cut margin. There will be anterior mucosal cut margin once you identify the tumor, identify the closest anterior mucosal cut margin of buccal mucosa. Now, this is middle third segmental mandibulectomy. Here you can identify this is the portion of mandible and you can identify the teeth. Uh, this is the tumor, large tumor involving lower alveolus going into floor of mouth and here involving inferior gingival-labial sulcus and also part of lip. Now, when we have the lip, you can see the lip mucosa. For lip, you can see the tumor is away from the margin, and here we are going to submit mucocutaneous cut margin, right lateral and left lateral. There will be this posterior mucosal margin also, and then rest of the margin which are closest to this, any other mucosal margin. We are also going to submit sections of bone and skin in this kind of specimen. So, just to summarize, what are the sections? Tumor representative sections, mucosal, soft tissue, and bony cut margin, adjacent tissue, including bone and skin if they are present, separately sent tissue, and nodes. So, this concludes the oral cavity specimen. Let's go to the next subside, which is nasal cavity and paranasal sinuses. So, if you see, this is the anatomy. You have nasal cavity, and then four paranasal sinuses. This is frontal, ethmoid, maxillary, and there is this nasal cavity here. Sphenoid is on the back side. So maxillary sinus is divided into two parts. That is about maxillary, even maxillary, the maxillary specimen is also divided into two parts. And the line that divides is called as Ongren's line, which is an imaginary line, extends from medial canthus to angle of mandible. We'll see how it looks like. But then it divides the maxilla into suprastructure and infrastructure. Suprastructure is a posterior superior part of maxilla which is closer to orbit. Infrastructure is antero-inferior part of maxilla which is closer to the palate. Now, why it is important to understand whether it is suprastructure or infrastructure? Even the maxillectomies can be many times suprastructural, infrastructural if the tumor is small. And suprastructural maxillary sinus tumors, they have worse prognosis because usually they present late and they show early spread to adjacent structures such as orbit and skull base because these are the structures which are very close to the suprastructural part of maxillary sinus. So let's see what is this Ongren's line. You can see there is medial canthus and this is the angle of mandible. If you draw an imaginary line, there is this suprastructural maxilla and infrastructural maxilla. So what are the types of specimen we get from nasal cavity? It can be endoscopic endonasal resection. Now here, for endoscopic endonasal resection, we cannot make out the margins. What is important is that the specimen usually is sent in multiple parts. So they will send the tumor separately, which will be in bits and pieces, and we submit entirely. Then the relevant tissue at the margin will be sent separately. So surgeon may send you the portion from ethmoid sinus, may send you from cribriform plate, and there are many other structures they will separately send it. We have to identify each and every structure in the specimen bottle. We cannot orient that because these are going to be in bits and pieces. So we can submit everything separately with a proper section key. What are the sections that are showing containing the tumor section, and what are the sections that are containing the rest of the tissue. So here the block key or section key is very important. to make sure that we can identify the tumor and the rest of the important tissue near the margin. So the rest of the maxillectomy specimen can be a limited maxillectomy when one or two walls are excised. And here again, the um, orientation of specimen can be difficult. If the surgeon has not oriented for you, please talk to him before we cut the specimen. Infrastructure maxillectomy usually includes lower part of maxilla. Now, many times this we can orient it because it includes the part of upper alveolus and palate. So orientation is possible if it includes alveolus and palate. Suprastructure maxillectomy, again, it includes upper part of maxilla. It may or may not be, we may not be able to orient it. So if required, we can talk to the surgeon. Now, subtotal maxillectomy and total maxillectomies are, most of the times we can orient them properly. We can identify the maxilla because that contains almost, even for subtotal maxillectomy, major portion of maxilla is there. Most of the part of palate and alveolus is there. So, but many times the orbital floor will be excluded. Now, total maxillectomy can contain orbital floor or may not, most of the times it contains orbital floor or roof of the maxilla. And sometimes we may get total maxillectomy with orbital excitation, which contains eyeball. Now, here again, the orientation is possible because the eyeball is there, and we have total maxillectomy, which you can identify based on the laterality, which is the lateral side and medial side. Craniofacial resection, not a very common specimen, but again, this can be difficult to orient, may contain dura also. So, in that case, if it is not oriented by the surgeon, first talk to the surgeon, identify each and every component because here the submitting margins and adjacent tissue, including dura, can be tricky, and we don't want to miss any dural involvement. So, we have to identify which portion of the specimen represents the dura which is closest to the tumor and how we can submit it. So if you look at the palatectomy or wide local excision, it can be a just smaller specimen with orientation. If uvula is included, we can always orient it. You can identify the mucosal margins, submit the margins, submit the tumor, and so on. Now, rest of the maxillectomy specimens can be medial maxillectomy, it can be infrastructure maxillectomy, suprastructure maxillectomy, or we can have a subtotal maxillectomy here, total maxillectomy including orbital floor, and then maxillectomy with orbital exenteration. Now, I'm showing you one specimen of total maxillectomy which contains the upper alveolus and palate. Now, here we can identify this is the palate portion and upper alveolar portion. The tumor is involving upper alveolus and palate. And this is the portion, the superiormost portion is from the nasal cavity. So you can identify there is this medial portion of palate which represents the medial bony and mucosal cut margins. This is the portion of hard palate. Then posterior mucosal cut margin and anterior mucosal cut margin are there, which we need to identify and submit them. And lastly, this is the lateral side of the lateral view of the same specimen. You can identify this is the alveolus and the lateral mucosa, and this is the lateral mucosal cut margin. So identification of tumor, its extent and margin is very important for for any specimen and can be tricky for head and neck specimen. This is another specimen of infrastructure maxillectomy. We are looking at it from the oral cavity view or inferior side. From inferior side, you can make out there is this alveolus here, and the tumor is destroying the upper alveolus, and there is this portion of palate here. And if you see the margins, there is anterior mucosal margin, there is medial mucosal margin, posterior mucosal margin, and lateral mucosal margin. Again, we will be submitting bony cut margins, which can be again bony cut margins for maxillectomy specimen. They are different for different type of specimen. So usually for infrastructure maxillectomy, usually we have palatal and enteromedial, that is the jawbone cut margin. Plus we may include there may be portion of maxillary antrum included. So maxillary antrum bony cut margins can be submitted. But rest of the like suprastructure maxillectomy or any other specimen, it's better to discuss first with your superiors, with the surgeons to identify which bony cut margins are important. When we get orbital exenteration specimen with the maxilla, I'm not talking about any orbital exenteration specimen for cases like retinoblastoma and all. This is something like which is the tumor which involving suprastructural part of or maxilla or ethmoidal sinus, and we get orbital exenteration specimen. Here we have to slice the specimen first and to see whether it is involving orbit or eyeball or not. Then eyeball, we need to submit optic nerve cut margin. Then this is called a PO section, through and through cut section of the eyeball going through pupil and posteriorly to optic nerve. And that section has to be submitted. In addition, the closest portion of eyeball, which is closest to the tumor, if it is close to the tumor, with tumor, we have to submit. And all these relevant sections like tumor with eyeball, if it is involving eyeball, otherwise if the eyeball is free, then you can submit the eyeball sections, optic nerve sections, and that has to be sampled and submitted for further processing. So what are the sections to be submitted? Just to summarize, tumor, all cut margin, other specific cut margins like or optic nerve cut margin, adjacent tissue, separately sent tissue, and nodes. So with this, we go to the next specimen, larynx. So before understanding the anatomy of larynx, we need to understand the anatomical divisions of the larynx. It is supraglottis, glottis, and subglottis. So what is supraglottis? It extends from the tip of the epiglottis to the ventricles, includes epiglottis, aryepiglottic folds, false guards, arytenoids, and ventricles. Glottis is a portion of almost 1 centimeter, and it extends from the ventricle to zero point 0.5 to 1 centimeter below true vocal cords, includes vocal cords and anterior and posterior commissure. Subglottis extends below the glottis, the lower boundary of glottis, up to the inferior boundary of cricoid cartilage, and then you get the trachea below that. Now, there is always a term discussed that transglottic carcinoma. What is transglottic carcinoma? When the tumor involves the both sides of glottis, or that is, it crosses the ventricles and involves both true and false cords. It is usually called as transglottic carcinoma. Now, in addition to that, we need to understand paraglottic space and pre-epiglottic space. What is paraglottic space? It is located anterolateral and deep to the ventricles, contains connective tissue and adipose tissue. We'll see it in the diagram soon. And pre-epiglottic space, which is located anterior to the base of epiglottis, and it contains again adipose tissue and connective tissue. Now, why it is important? Because we have to sample all these spaces. With tumor, paraglottic space is always sampled. Pre-epiglottic fat, we have to sample it separately because we need to know whether it is involved by tumor or not. So let's look at this larynx. If you see that the topmost portion, epiglottis, there is this thyroid cartilage, arytenoid cartilage, cricoid cartilage, and the middle portion is portion of the glottis, which we'll see it in the next diagram. You can see here. Supraglottis is epiglottis up to the ventricles. Then the middle portion is glottis, which includes true cords, part of ventricle, and false cord comes in the supraglottis. From false cord onward, it will start the glottis portion. Below the glottis starts the subglottis, and this is the subglottis portion. Then we have paraglottic space. You can see the yellow space just beneath the false cord and true cord. You have the yellow space, which is yellow tissue, which is usually loose fatty tissue, and this is the paraglottic space. Then we have thyroid cartilage, which is blue in color. There is this hyoid bone, and below is cricoid cartilage. This is another view which shows you pre-epiglottic space. So you can see this is the epiglottis. There is thyroid cartilage, hyoid bone, and in between you can see there the base of the epiglottis anteriorly. This is pre-epiglottic space, which is usually contains fat. And when we gross the specimen, we have to submit this pre-epiglottic pad of fat. So what are the types of specimen in laryngectomy? It is laser excision for the small cancers, T1, T2, glottic or supraglottic cancers. Partial laryngectomy, T1 and T2, glottic and supraglottic cancers. Near total laryngectomy for advanced laryngeal cancers and total laryngectomy. So total laryngectomy contains entire larynx and it will include upper tracheal rings as well. And sometimes it may be laryngopharyngectomy specimen if the tumor is going posteriorly. A portion of pharynx may be included in that. So if you see a laser excision specimen, usually um, it is oriented on a thermocol or some other surface by the surgeon, like anterior, lateral, posterior, and medial. We have to ink the margins and submit separate margins and rest of the specimen with proper documentation. This is a kind of tricky specimen. We have to be very sure and all the margins with the lesion need to be submitted separately. Now, laryngeal tumor is what I'm showing is a quite a big laryngeal tumor here. Here you can identify the supraglottis, glottis portion, subglottis portion. There are anterior strapuses and there is big tumor. This is a cut section of the larynx, and the mucosal surface is seen on the right hand side. This is another total laryngectomy specimen. As you see here, the tumor is again involving the glottis and adjacent area. You can see the epiglottis. Inferiorly, you can see the tracheal rings. Now, how do we submit the margin? So there is the lateral mucosal margin, right lateral mucosal margin, left lateral mucosal margin. There will be anterosuperior mucosal margin near the epiglottis. In this case, it is far away, but we'll submit it. And then, as because we have cut it, the posterior inferior margin comes here. You can see it in the next picture. This is the posterior inferior cut margin, and you can see here the tumor involving glottis. Again, we have to also submit the inferior tracheal margin, which is a shaved margin. So the four mucosal margins will be radial margins, and there will be the shaved margins. What we next do is, once we submit the margin, cut the larynx in two halves, and we have to submit sections from supraglottis, glottis, and subglottis separately. And while submitting this section, include the tumor in that area. So in this area, what the tumor looks like, it is involving also both sides. It's not only one sided tumor, it is going to contralateral side as well. So we can submit sections of supraglottis, then glottis with tumor, and subglottis. So for bilaterals, right supraglottis, glottis, subglottis, left supraglottis, glottis, subglottis, and with the tumor, and even if they are not involved by the tumor, we have to submit all the sections. So sections to be submitted, tumor with representative sections from bilateral supraglottis, glottis, subglottis. This is for total laryngectomy. For partial laryngectomy, again, identify the margins and tumor with adjacent area. Here we may not be able to say whether this is in the supraglottis, glottis, or subglottis if it is only portion of larynx is submitted. Margins, pre-epiglottic pad of fat needs to be submitted. Adjacent tissue. Now, usually there is thyroid lobe included in that. So, thyroid lobe, whether it is involved or not, we have to see. Submit the sections from thyroid lobe. If tracheostomy stoma is present, try to see whether it is involved or not, and a representative section from tracheostomy stoma can be submitted. Revise margin and neck nodes, they are all submitted. So this is again a summary of all head and neck cancer specimens. When you cross them, just a flow chart, identify specimen, orient it, describe components, identify tumor, describe location, extent and measurements, identify all margins, take the measurements, identify adjacent tissue, ink the margins, submit sections from tumor, adjacent tissue including bone, skin, and other anatomic structures like orbit and thyroid lobe, depending on the type of specimen. So with this, we cover three major subsites in the or major organs in the head and neck area. Important along with this, we need to understand that there's one important section is cervical lymph node dissection, because most of this specimen will accompany or will have the um, ipsilateral or sometimes bilateral cervical lymph node dissection, which are most of the times these are regional nodes. So we need to understand again anatomy of the cervical nodes and how they are anatomically placed. Here, the most important anatomical structures we identify is sternocleidomastoid muscle, neck vessels, especially IJV, internal jugular vein, And then in that context, we can identify the structures or the different levels of the lymph nodes. 1A is in the midline, and then 1B is close to the submandibular gland. Then starts the 2A and 2B. 2B is slightly posterior to the 2A. Then middle portion is level 3. Then below is level 4, and little posterior is level 5. Above superior is 5A, inferior is 5B, and level 6, which is anterior or central compartment node. So what are the types of neck node dissection? Radical neck node dissection, which is not commonly done now, it includes all levels 1 to 5, 1, 2, 3, 4, 5. It also includes sternocleidomastoid muscle, internal jugular vein, and spinal accessory nerve. Now we have to understand this is quite a morbid surgery, and patient later on suffers from a lot of other morbidity. So nowadays the goal is to minimize the node dissection. So modified radical node dissection, it includes again all 5 levels, but it may or may not include one of the following level structures. That is, most of the times it's sternocleidomastoid which may be included in that, and there's internal jugular vein sometimes, or spinal accessory nerve, or all the three structures can be spared. So if these three important structures, sternocleidomastoid muscle, IJV, and spinal accessory nerve are spared, definitely this is less morbid event compared to radical neck dissection. Now, still less morbid is selective neck dissection. Here, only the specific levels of neck nodes are dissected. It can be 1 to 3, which is also called a supraomoid neck dissection, or it can be 1, 2, 3, 4. Or sometimes when we get any laryngectomy specimen, the levels are 2 to 4 levels, bilateral level 2 to 4, 2, 3, 4 each side. Sometimes it can be posterolateral neck dissection, that is level 2, 3, 4, and 5. So once we understand these neck node levels and types of dissection, how do we gross them? So there are two ways the surgeon may send the neck nodes to you. One, the surgeon can send entire nodal dissection together, which includes part of some sternocleidomastoid. If sternocleidomastoid is present, and if submandibular salivary gland is present, we can decide what levels are the nodes. Each level we can identify separately. Now, suppose you get two levels, 2 to 4 nodes together without any muscle tissue. Here we cannot orient the specimen, we cannot identify the levels separately. The best way is submit each and every node, but level that as level 2 to 4 neck dissection. Now, what happens when we get level 1 to 4 or 1 to 5 with submandibular gland and with sometimes with sternocleidomastoid muscle? So, what we can do here is separate 1B nodes from the rest of the specimen first. So 1B nodes can be identified with submandibular salivary gland close to that. They should be submitted separately. So salivary gland serves as as an anatomical landmark here. Then if we identify sternocleidomastoid muscle, if it is included, it is divided into 3 levels. Superior is the level 2, middle is the level 3, and inferior is level 4. Now this is all possible if the muscle is included. If the muscle is not included, if IJV is included, still possible to do that. Otherwise, we may not be able to differentiate all the level 2, 3, and 4 uh, nodes separately. Excuse me. So, if the specimen is not oriented, the rest of the levels they need to be sampled together after consulting the surgeon. Okay. Now, sometimes, most of the times in our institute as well, the specimens is sent separately. So our surgeons will send each and every level separately. Then in that case, it's easy. You just get that specimen bottle, level 1B, 2A, 2B, whatever it is, identify all nodes. Now, how do we submit the node? First thing, dissect each and every node. All nodes needs to be dissected. You should not leave any node behind. All nodes need to be dissected. The largest nodes are either bisected or sliced. If this is a larger nodal mass, suppose this is a 3-4 centimeter nodal mass, you just slice it, make sure that you find some area of extranodal extension grossly. Even if not, try to submit one complete plane of that node in a grid form, like one complete slice if possible. We make a diagram of that and submit the entire slice, because we don't want to miss any extranodal extension. All of you know that extra presence of extranodal extension in oral cavity tumors or in neck nodes changes the stage of the node. Nodal changes the nodal stage. Now, if the nodes are matter, that needs to be documented. Then submit all the sections. Larger nodes, bisect and submit entire node. Smaller nodes, if they are really thin, you can just submit entirely. The goal is that dissect each and every node, submit entirely, unless it is a grossly metastatic node. We know that it's a very big node, grossly metastatic. Then submit representative section, but make sure that you don't miss extranodal extension. So we have to submit a gross examination here is very important for matted nodes, large nodal mass, and grossly involved nodes. We have to identify the area where the tumor appears to go out in the adjacent fat. So all nodes to be submitted, each level submitted separately if possible. And suspected gross extranodal extension, submit the adjacent tissue along with the node. Now, additional sections may be required for large nodal masses and matted nodes. So with this, we conclude the grossing part of head and neck specimen for major subsites. Now let's go to the frozen section and we'll follow it. It will follow by discussion on cancer data sets briefly. So frozen section, we need to understand what is the indication of the frozen section in head and neck surgery. Most commonly, it is either for surgical margins to know whether excision is adequately done or not, or whether the surgeon needs to revise a particular margin. Another important indication is lymph node to look for metastasis. Now, why it is important? Because the surgeon may send you separately like level 1B and 2 nodes to look for metastasis. So if they are not involved, they may stop at the level of a selective neck dissection, may stop at the level of level 3 or level 4. But if level 3 or 4 are involved, then they may complete and do modified radical neck dissection. Now, sometimes surgeons may send you for primary diagnosis, which is obviously is not always easy and we don't encourage, but sometimes it is needed. There are certain surgeries like for surgeries done for sinonasal tumors, especially adenoid cystic carcinoma, when the adequacy of surgery is very difficult. Many times the tumor extends to adjacent tissue, and in that case, to to assess the adequacy of surgery, surgeon may keep sending you tissue from different parts, like tissue from cribriform plate, tissue from close to ethmoid sinus, and so on, to make sure that that tissue is not involved by tumor. Sometimes you may get a nerve, the segment of a nerve with cut and inked, and that we are supposed to see whether this is involved by tumor or not. So here, we mainly it is to look for or to assess the adequacy of the surgery, which is important in that case. So again, frozen section, the steps are same. First, clinical information is necessary. So clinical information, what is the primary diagnosis of the tumor? If we don't know what tumor we are looking at, we don't know what we should look for in the particular tissue to see whether it is involved by the tumor or not. Then treatment history, primary diagnosis, what type of surgery, what is the indication of frozen section, everything is important. A quick meticulous gross examination is very, very important before we start frozen section. And if we are looking at lymph nodes, try to find out all nodes, bisect them and see if it is grossly involved. If grossly not involved, we have to submit all nodes. But if any node grossly involved, we can submit only that half and wait for the section to inform the surgeon. And other nodes may not be needed. We don't have to sample them in frozen section. For primary tumor, orientation and inking is the same what we have seen earlier. If there is any query, get it solved immediately. Cut the margin, take the margin or tumor tissue, whatever is required. Embedding of tissue is important because the tissue, whenever you are placing it on the chuck for cryostat, the topmost portion is the one which is going to be cut first. So the portion that we want to see under microscope should be facing up, and ink margin should be properly identified in that tissue. Um, Fatty tissue should not should we should discourage to we discourage freezing of fatty tissue because it's very difficult to cut them, and we really don't get good sections. Bony tissue never to be submitted for frozen section. The cryostat that we have, most of the hospitals, there we cannot cut any bone. So if we are getting any soft tissue with some bony chips, we have to remove the bony chips. Otherwise, it's going to damage the blade. Frozen section. So when we should not do frozen section for bony tissues, fatty tissues. Now, tissue when the patient is a known case with infections such as tuberculosis and HIV, we cannot always avoid frozen section, but pathologists should be informed. Uh, the universal precautions, when we take universal precautions, usually they take care of all infections. But if you really were concerned about the severity of infection, then maybe we should know that the specimen is infected specimen. If the tissue is limited, available tissue is limited, and they're sending it for primary diagnosis, and we know that we may lose this tissue, very tiny tissue, we may not be able to cut it in the frozen section. It's best to tell the uh, surgeon that we cannot submit it for frozen. We are going to lose the valuable tissue, and it's best to submit it for paraffin section. Or sometimes, many times, if they send it to you, they will send separately in formalin. So they will send some tissue for frozen section and some tissue separately for formalin. In that case, whatever the tissue we have received for frozen section, we can submit entirely and look for the specific pathology we want to look for. Definitely, curiosity on part of the surgeon or patient to get the diagnosis as early as possible is not an indication for frozen section. That should be discouraged. So again, this is another specimen, a bite composite resection sent for frozen section. We have inked the margins. There is this buccal mucosa. We see the tumor here involving the lower alveolus. And look at the scalpel, how it is placed. This is the closest margin. We are spacing it radially, perpendicular to the margin. We'll make two parallel sections and take that margin for frozen section. Now, how it looks under the microscope, why inking is important? Because here you can identify the ink, right? And this is the base or soft tissue cut margin. There is the tumor here, and you can see that there is some distance between the base and the cut margin and the tumor. We can always measure this distance on the microscope, and we can tell the surgeon how far it is. Now here we have inked cut margin of the nerve. This was inked here. We submit entirely the nerve, and we can see that the margin is completely free of tumor. Now, rarely you get salivary gland tumors or some other tumor for primary diagnosis. This is one of the case like that. You can see there are cystic spaces, and then they are lined by epithelial tissue. At higher magnification, you do see some cells containing mucin. So here we could tell them this was a mucoepidermoid carcinoma with a lot of cystic spaces. It could be more likely low or intermediate grade, but certainly we can't say about grade many times. Now, in some cases, the surgeon may ask you, can you tell us high grade or low grade? Why it is important? Because especially for parotid tumors, when it is superficial parotorectomy and the tumor is close to the facial nerve, if we can tell them it is high grade tumor, they will take out the deep lobe with the nerve. They will not spare the nerve. But most of the time, surgeon want to spare the nerve. So if they know that this is a low grade tumor, they will try to spare the nerve as much as possible. Again, lymph node for metastasis, you submit the entire node and you see, look for any metastatic focus beneath the capsule and rest of the lymph node tissue. And here is one lymph node which shows metastatic focus just near the capsule. There is a pitfall here. So this is one of the lymph nodes we got for frozen section. And if you don't know what it is, sometimes a person may call it as metastatic carcinoma. So fortunately, first pathologists could identify this looks different. The cells are quite oncocytic. And then when we asked them where exactly it is from, so they said it is level 2 close to parotid tail. Then our guess was this is Warthin's tumor. And when we look at the paraffin section, this turned out to be Warthin's tumor. So we have to understand the pitfalls, inclusions in the lymph nodes, presence of Warthin tumors, and all of this should not be called as metastatic tumors. So, sentinel lymph node biopsy, which is not common in head and neck region, is this the first node that receives the lymphatic drainage from carcinoma? And here, the crossing of sentinel node is very, very important because otherwise, we bisect the nodes or slice the nodes and submit them. But for sentinel node, it is we don't want to miss even the smallest portion of our smallest focus of metastatic tumor, because here, if we say sentinel node is negative, the surgeon is not going to go for next rest of the nodal dissection. So our job is to identify when is smallest focus of uh, smallest metastatic focus in frozen. Obviously, frozen has limitations for that. So how do we how do we proceed for that? Go with sentinel nodes. So frozen section is less sensitive, and there are false negatives for sentinel nodes. But when it is positive, which is really helpful. If it is small metastatic focus, it may be missed. But when sentinel node is positive, we can tell them it is positive. Surgeon can proceed with rest of the lymph node dissection. So again, there are technical issues. Cutting the fatty nodes and step sectioning is not feasible. So what do we do? Traditional lymph nodes, we just small lymph nodes we submit entirely. The larger nodes we bisect them and submit them. Right now, for sentinel nodes, we have to cut them at different levels, separate sections levels. So bisected node is not done in sentinel node unless it is very very small node. Rest of the nodes are the sliced or bread loafing is done, and each and every slice is put on the chuck for frozen section. That way, we are examining maximum surface of the lymph node. And this is then finally the way it is to be cut is smallest node bisected. Anything more than 5 millimeter, bread loaf it, sub, uh, place each and every section on the chuck so that the final stain slide shows all the slices and you can identify the metastatic focus if it's present. Should we go for step sectioning here? No, we don't. We cannot go for step sectioning during frozen section, although it depends on the institution if they have some different protocol. Ideally, step sectioning is done for paraffin section. Why it is 2 millimeter? Because the we don't want to miss at least macrometastasis. Micrometastasis may be missed even with this. So to summarize, frozen section is a valuable diagnostic tool, especially for intraoperative diagnosis. It is cooperative effort of both surgeon and pathologist. There should be clear and prompt communication, and it helps to refine the pre-surgical diagnosis as well as it helps to decide the extent of surgery and lymph node dissection. So with this, we are coming to the last portion, that is cancer data sets. What are cancer data sets? We have seen earlier, these are the structured collection of data related to cancer, and they are quite evidence-based, and they provide standardized reports that enables pathologists to provide standardized reports. So who decides the cancer data sets and how do we get them? They are all freely available on this website. International collaboration on cancer reporting, Royal College of Pathologists, and College of American Pathologists, all of them have cancer data sets with detailed explanation of each and every parameter or element of the data set. So this is certainly is valuable for any pathologist who is signing out the radical surgery specimen. Again, we need to understand AJCC cancer staging manual as well. So here the concept of core and non-core elements is important. We need to understand what is core element. So core elements are essential for clinical management, staging and prognostication of cancer. These elements have evidentially support either level 3, 2 or above, and ancillary studies whenever necessary, like immunohistochemistry, molecular studies whenever necessary, they are included in core elements. Now, what are non-core elements? They are the parameters that are unanimously agreed, although they are not supported by enough evidence, but they could be clinically important and recommended as a good practice. Now, in addition to that, there could be some optional elements depending on the particular institution and when the group of surgeons and pathologists can decide any other elements they want to include. So, what are the core and non-core elements in oral cancer? So, those which are in black, they are all core elements. Clinical information, operative procedures, specimens submitted, tumor site, tumor dimensions. Now, greatest tumor dimension is a core element. Tumor focality, rest of the two tumor dimensions, block identification key are non-core elements. When you look at the microscopy, tumor type, tumor grade, depth of invasion, pattern of invasion, extent of invasion, LVI or lymphovascular invasion, perineural invasion, margin status, ancillary studies, pathologic study, staging is everything is core element. While coexistent pathology, if there is any other pathology in adjacent structure, that is non-core element. For nasal cavity tumor, more or less same. If you see here, tumor dimensions here is non-core element because many times when we get the specimen in bits and pieces, we may not be able to give exact tumor dimension. And nevertheless, whenever we have a specimen with intact tumor, try to give all the tumor dimensions. While rest of the and block identification for identification key for all specimens is non-core element. Again, for histology, there is no depth of invasion here, no pattern of invasion, but the rest of the parameters or elements are the same, including precursor lesions. Now, here precursor lesions, such as if you are dealing with sinonasal squamous cell carcinoma, so if there is presence of Schneiderian papilloma or sinonasal papilloma, then we have to mention that what type of papilloma, inverted or whether it is oncocytic, everything has to be mentioned. Ancillary studies can be core elements in some of the cases. Some tumors where ancillary studies are required, like diagnosis of nut carcinoma or diagnosis of some other tumors where immunohistochemistry, sometimes molecular pathology is required. So there, these are core elements, but sometimes ancillary studies may not be core element. It depends on the tumor type. Pathologic staging again is a core element. Larynx core elements are again clinical information, operative procedures, specimens submitted, laterality, focal. Here, focality is tumor focality is core element, tumor dimension, the greatest one. When we come to the microscopy, pattern of invasion is included here, but this is a non-core element. Otherwise, rest of it is similar. What you see here, tumor type, tumor grade, extent of invasion, LVI, PNI, margins, ancillary studies, and pathologic studies, or that can be included as a core element. Now, I have now not covered oropharynx, nasopharynx, and salivary gland in crossing, but we'll just briefly look at the core elements. Clinical information and everything else is core element as similar to what we see in other specimen. And again, histology, the same type of core and non-core elements are here, are they important, but ancillary studies are obviously important because especially for oropharynx, we know whether it is HPV mediated or not. So P16 is essential. So ancillary studies can be core element in those tumors. Salivary gland, again, clinical information and specimens, tumor site, tumor dimensions, but tumor focality is non-core element. In case of histology, tumor types, grade, extent, LVI, PNI, margin status, pathologic staging is okay. But ancillary studies here are non-core elements. Coexistent pathology is non-core element. Now, before concluding this talk, I'm going to just go through some of the core elements quickly For tumor dimensions, how to take them grossly. All three dimensions, then we have to measure them in millimeters. Greatest dimension is essential, but other two dimensions should be given. If the tumor is small, then microscopic dimensions need to be mentioned. So here we have hemiglossectomy specimen. We take two dimensions grossly, and when we slice the specimen, the thickness will be also included. Same is true for hemimandibulectomy specimen. The dimension grossly, slice the specimen, look for the or measure the third dimension. Now here we need to understand depth and thickness. Thickness is the topmost portion of the tumor and the lowest end of the tumor, while the depth of invasion is measured from the adjacent mucosa. So tumor thickness and depth of invasion are different, where tumor thickness can be assessed macroscopically, but depth of invasion, which is taken from basement membrane of mucosa to the deepest portion of invasion of tumor, which is best taken on microscopy. Now, it predicts the recurrence and nodal involvement, and we know that in oral cavity tumors, depth of invasion decides the staging of the tumor in certain tumor stages. So here we have some of the diagrams which you can see that basement membrane and the lowest portion, and here it is the depth of invasion, while the tumor thickness is the entire tumor from top to bottom. Same is true for an ulcer infiltrative tumor. You can see that this is the depth of invasion which is in the red, and tumor thickness will be from the top portion to the deepest portion of the tumor. Here we have one of our sections. You can see how we decide the tumor depth of invasion. First, identify the basement membrane, draw a horizontal line, then draw a plumb line to the deepest portion of the tumor, and the red portion, this is the arrow, that distance needs to be measured to assess the depth of invasion. And this is another section similar to that. We can see this is the depth of invasion. Histological tumor type, I'm not going to go into the detail, but we know that most of us will follow the WHO classification for the tumor types. Histologic tumor grade, again, squamous cell carcinoma can be well, moderate, poor. Mucoepidermoid low, intermediate, and high grade, but there are various classification system. Most of other carcinomas are low and high grade. Patterns of invasion, there have been different type patterns of invasion they have been described in separate by different groups. And initially it was Ryan's pattern 1 to 4, then modified by Brandwin Gessler pattern 1 to 5, and then ICCR recommends three patterns: cohesive, which corresponds to 1 to 3 patterns of Brandwin Gensler; non-cohesive, which corresponds to 1/4 pattern 4 of Brandwin Gensler type; and disperse, which corresponds to the pattern 5 of Brandwin Gensler type. So here we can see cohesive, that is in large islands; non-cohesive is in small islands; and individual cells more than 1 millimeter from main tumor, which is dispersed pattern of invasion. These are some of our examples. Pattern 1, which is pushing type, cohesive. This is pattern 2, pushing fingers again and arranged close to each other, but these are broad pushing finger-like projections. This is pattern 2, again cohesive pattern. Pattern 3, with tumors showing separate islands, but they are close to the tumor and they are having more than 15 cells. This is again cohesive pattern. This is cohesive pattern again, pattern 3, pattern of invasion 3 type. While here we can see there are small clusters, very small clusters, although they are close to the tumors. This is the infiltrative pattern, that is pattern of invasion 4. And here again is higher magnification pattern of invasion 4. It is still close to the tumor. While this is, you can see here, the black big back line on the right hand side represents the main tumor, and there is another tumor island is seen away from the tumor. And this is the pattern 5, or what is called as dispersed pattern by ICCR. This is the higher magnification of the same. You see there is there in between the tumor and the tumor island, there is perfectly normal looking muscle and other tissue. And most of the times we see mixed patterns, so we describe predominant pattern of invasion and worst pattern of invasion. So reporting margins, we have to report them as free of tumor, close to tumor, or involved by tumor. Sometimes cannot be assessed if the tumor was sent in. multiple uh, fragments. So this is how it looks like on microscopy. You have mucosa, overlying tissue, and there is this margin which is free of the tumor. Here again, there is ink you can identify and mucosa you can identify that is free of the tumor. Here we have a base at the bottom of the section. There is this tumor at the top. We're covered by the mucosa, and you can see the base is free of the tumor. This is the higher magnification, which is also showing base free of the tumor. Perineural invasion predicts aggressiveness, and we have to report perineural invasion present or absent, reported as extratumoral, intratumoral. It is desirable to mention the diameter of the largest nerve involved. Some people do mention the PNI density, although it is not really mandatory, it is not a core element. And if there are named nerves, like an inferior alveolar nerve is showing perineural invasion, we have to specify that inferior alveolar nerve shows perineural invasion. LVI, when present, you have to specify present or absent. Then adjacent organs, we have to specify whether bone is involved, medullary bone involvement or transcortical involvement. If it is skin is involved, whether it is ulcerated, and for laryngeal tumors, whether pre-epiglottic space is involved, thyroid cartilage is involved, cricoid cartilage is involved or not, adjacent organs are involved or not. So all these parameters need to be mentioned. This is one of our sections showing bone involved by squamous cell carcinoma. And adjacent organs, if they are showing any coexistent pathology, that has to be mentioned. And neck node dissection, the core parameters is clinical information, specimen submitted, and histological tumor type, grade, margins, lymph node status, whether positive or negative, ancillary studies if required, regional lymph node categorization if necessary, like it is selective is it selective node dissection, is it contralateral, whether it is non-regional node, we have to specify that. Sentinel node biopsy at this point, they say non-core, but whenever it is you get it, we have to go for the step sections, and if required, we have to go for a sentinel node protocol, which is quite a it's like extensive protocol, and that it really needs a different type of kind of it takes a lot of time and a lot of sections to examine that. Any other pathology like granulomas or anything, that is a non-core non-core element. So how do we report the lymph nodes? Total number of lymph nodes identified on microscopy, total number of lymph nodes which show metastasis at each level, the size of the largest metastatic deposit, then extranodal extension present or absent. If it is present, you say whether it is major or minor, which is non-core, but it's better to specify the size of extranodal extension, which is measured perpendicular to the lymph node capsule. So whether it is 2 mm or below, which is minor, or anything beyond 2 mm is major. So here we see a lymph node with metastatic focus, and here we see a lymph node showing extranodal extension. So with this, I'm concluding this webinar, and the take-home message here is knowledge of anatomy, clinical findings, radiological findings, type of specimen is very essential before we start crossing oncology specimens. Orientation, identification of specific component is necessary. Contact the surgeon if required. This is very, very important. And most of the laboratories, when they are getting head and neck specimen, we do contact surgeons if we don't get any idea how to orient the specimen. Inking of specimen, identifying tumor and its margin, frozen section when it is used wisely, it's a valuable tool. And cancer data sets, there is no actually alternative for that. Cancer data sets are valuable part of specimen reporting or histology reporting of even grossing and reporting of any cancer specimen. This provides a checklist, and this provides all the elements that are necessary for further treatment. So there should not be any excuse for not using for using cancer data sets. With this, I conclude my talk, and I'll stop sharing my screen. And if I'm happy to take any questions. Kedar, you are muted.
So, Dr. Patil, thanks a lot for this elaborate presentation. I think we really enjoyed it. You've meticulously took us through to these different types of specimens, along with the frozen section indications, and I think it really is helpful and a lot of practical points covered. I must appreciate your help for all these things. So we have number of questions. Actually, I'm glad to see number of questions. I wonder
Well,
whether we have
good.
full time for that. But let me at least try to get through as much as possible. You can be brief if you wish to be, but I think we have at least a dozen questions here. Uh, so let me start. How to count number of nodes if we have large matted nodes or we have encountering a matted lymph node size 4 to 5 centimeter in size?
So we can't count them, honestly. So there you specify these are matted nodes, give the size of the node, nodal mass or matted nodes. But here then grossing is important because here the number doesn't matter. It is the size of the node and extranodal extension, which is going to really change the stage of nodal stage in this case. So then, as I said, slice it and submit one complete slice with adjacent tissue to make sure that we don't miss any extranodal extension.
Okay. So next question, if there is an NACT specimen, is the grid submission is essential in buccal mucosa carcinoma?
So grade means, say, for NACT till now we do not have any tumor regression grade, honestly, but we have to make sure that it's definitely it is shown by many studies that complete response, which is called as pathological complete response or PCR, which is really good for which is a good prognostic indicator. So the thing is that here we don't want to miss the tumor. So if you don't see tumor grossly, submit as much as tumor bed and if required in grid format. If you see most of the tumor is viable, at least try to submit one slice of the tumor or two slices of tumor. So at least 4 to 5 sections in that tumor. So ideally try to submit entire tumor bed if tumor is not seen grossly. If tumor is viable, try to submit as much as possible, minimum 4 to 5 section. Ideally, grid is required to make sure that we don't miss any underlying bone involvement or skin involvement where we cannot make out difference, we cannot differentiate between therapy changes and tumor on gross examination. So here if we get the grid, we know exactly whether the tumor, viable tumor is there in the skin or bone. And that is going to change the stage of the tumor.
Okay. The next question is if you have a large specimen and if you are taking a shave margin, the sampling entire margin is going to generate lot of blocks, lot of slides. So do you take the only representative shave margin or what do you recommend?
That's a good question, I think, because shear margins are not really submitted entirely. So as I said, it is mainly for mucocutaneous margins, which are usually two margins only. Or it could be for bony cut margins. So bony cut margins are again limited. For mandible, there could be 1 to 3. Maxilla, there could be 1 to 3. Or it could be for laryngectomy, it is inferior tracheal margin. For rest of the margins, especially for mucosa and soft tissue, it is always radial margin. So in any case, uh, this is going to be, if it is radial, it is always representative. For shave, I think we can submit in 1 or 2 maximum blocks mandibulectomy shave margin. Same is true for tracheal margins. The rest of the margins can easily be accommodated in one cassette each.
So shave can be the closest kind of a closest soft tissue area.
Closest
We don't
bony cut
take
margin, bony,
bony cut margin.
bony
Okay.
or mucocutaneous.
Okay. What could be the ideal decal solution for bone decalcification?
So for routine, this is not, we are not dealing with bone marrow. So routine processing, whatever you are
For say
having at
hemimandibulectomy, maxillectomy specimens.
so for them, whatever we are using, even for like soft tissue bone and soft tissue tumors, whatever the solutions you are using in decalcifier with hydrochloric acid or any other, whatever there are multiple solutions available. So whatever you are using, you don't need that AGF solution, what we use it for bone marrows. Here, we regular decalcifier, so this decalcifying solution used for any other big bone tumors or any other, that is sufficient.
So
We don't need
formic
any
acid,
specific.
nitric acid, what will you say?
So I think nitric acid is still okay, but that will be very, it has to be really, we
Mhm.
have to make sure that it is not going to decalcify.
Okay. Yeah.
So it
So
depends
next,
on the whatever laboratory is using, but we
okay.
have to really monitor the decalcification, otherwise it's going to really destroy the tissue.
Okay. The next question is if the tumor is near the TM joint and there are tendons around TM joint, so do we need to get sections from all these tendons as soft tissue margin, similar to vaginal cuff cut margin, so on?
So entire is like we don't have to specify all cut margins, okay,
Okay.
unless that the surgeon wants it. Like surgeon sometimes may ink especially for specimen which include infratemporal fossa, they may ink that portion. So if they have
Okay.
inked it, definitely we can identify. If they want it, tell them to ink it. Because once you put the specimen in formalin, it's really difficult to identify the exact structure which is close to the. So only thing we can give soft tissue margin, but we may not be able to specify which tendon or which muscle.
Okay. Yeah, that's okay. For segmental maxillectomy or mandibulectomy, should we put the entire specimen in decal or should we try to separate the mucosa and soft tissue margin first? What do you recommend?
So the best way for any tumor with bone, so try to keep a little bit of tumor with with the underlying bone so that we can see the bone and tumor interface. Don't submit rest of the tumor in decal, but definitely we want to see the tumor and bone interface. So if you shave off entire tumor, we really don't know the tumor is really superficially eroding the bone or going inside. If it is going inside, definitely you can find out. But sometimes it is superficially eroding, which you don't want to miss. That doesn't change the stage of the tumor, but if it is superficially eroding the bone, not going inside, we have to mention that because usually CT scan, they describe that there is some superficial erosion and we have to identify that on microscopy. So keep little bit of tumor. So make sure that we see the bone and tumor interface.
Okay. The next one is in case of CA oral cavity from subsides other than gingiva, does superficial erosion of the mandible alone make it stage PT4A?
No, it doesn't. It doesn't. It has to be
That's a
going into
short
the
answer.
cortex.
Okay. Yeah.
Yeah, so that has to be transcortical or major part of
Okay.
cortex is destroyed. And when it goes to medullary cavity, obviously it is T4A, but it has to destroy more major part of mandible. Superficial erosion is just abutting and little bit eroding is not T4A.
Okay. So other question is when we have a additional separate margin, say along with a main excision specimen, and this additional margin is very thin and or flat piece of tissue. So do we dissect it or we embed it fully?
So when there is a flat margin, try to identify if it is inked by the surgeon. If
Okay.
it is inked by the surgeon, the embedding should be done that in such a way that the ink should be coming on one side and the rest of the tissue on other side. If it is not inked by the surgeon, but preferably submit entire tissue, how to embed it is important. Ink surface, as far as possible, should be on one side so that we can see the tissue and ink surface, identify the distance of the tumor from the ink surface.
Okay. What distance will you consider for free margin for oral cavity cancers?
So anything which is cutting the tumor, that margin, if the tumor is cut at the margin, that is involved. Okay,
Okay.
so anything beyond that is considered as free, although like 3 to 4 millimeter, 5 millimeter of margin, at least 5 millimeter of margin, the surgeon would like to have. But for us, we don't have to specify it is close or not. If we can give the distance between the tumor and the margin, that is sufficient. So tumor cut at the margin, if that is involved margin, if the margin is intact but tumor is close to the margin, give the exact distance 1 millimeter, 2 millimeter, or less than 1 millimeter, whatever it is. So obviously 1 millimeter, 2 millimeter is close.
But would you recommend, say, it should be at least 3 millimeters, it should be at least 5 millimeters? So would you have recommendation
See,
for that?
ideally 5 millimeters is minimum, but that we don't recommend. Okay,
Okay.
so there are various studies where there are in some certain cases the margin can be close, but the surgeon cannot go beyond that.
Yeah.
He cannot dissect the tissue beyond that. This is particularly true for head and neck. So for us, we can say that it is free or not and how far it is. So
Okay.
we don't have to recommend whether it should be revised or not unless and until it comes to frozen section, and then the surgeon may want to know whether it is really close or not, especially when they don't have much space to revise it.
Okay. I guess the next question is about what is the appropriate time to issue a result? I guess it is about a turnaround time.
Turnaround time, again, it depends on your institute, and again, it depends on what kind of specimen it is. Okay. So if you really see, there are some different institutes have different turnaround times, but these are big specimen. So 4 to 5 days minimum are required, majority of the specimen. With decalcification, more time is required. If you go back, sometimes you have to go back, submit more sections. You have to do some ancillary studies. Again, you will need more time. So if it is roughly, if you don't have any bone included, 4 to 5 days is good enough. Now remember, even if it goes beyond 6, 7 days, they're not going to start immediately any chemotherapy or radiotherapy. There is going to be some time gap in between. So ideally, within a week or 10 days, we have to issue the report as much as possible. That's the best time. Earlier is better.
Okay. Next is an interesting question. Which measurement is considered accurate for commenting distance of margin from tumor? Is it gross or is it microscopy on frozen section or microscopy on paraffin section?
So again, there is a caveat in this. Okay, gross is the always going to be the largest one. Gross, even on frozen section. The moment we put it in the formalin, the specimen is going to shrink. That margin is going to be closer. So gross margins are best distance wise. But whenever we are commenting it on microscopy, again frozen section margin and paraffin section margins are going to be different. The same margin which is away in frozen section may be closer in paraffin section. But then in that case, in paraffin section, it is kind of there is some shrinkage is there. So if we have commented something on frozen section, that margin is the best. Gross is always best. But when we look at the microscopy, if it is not submitted for frozen section and microscopically anything is coming closer to that, we have to document it. So there is no good answer for that. We are not going to do frozen section for each and every margin. So we have to rely ultimately on microscopic margin. But
Okay.
ideally, gross margins are best.
Okay, one of the question is as did you say we have to submit the whole lymph node for frozen section, not just a representative section? I guess a little bit of
Yeah.
clarification is required. Maybe how do you tackle the nodes and
So,
or the sentinel nodes? Yeah.
so Sentinel node is again different. We rarely
Okay.
get them, but we do get them. For Sentinel node, you have to bread loaf and submit very
Submit all the
extensive
tissues.
grossing protocol is there. For
What
other
should be the
nodes,
policy
yes.
for other nodes? Huh?
Other nodes, a big node has to be bisected. Try to submit as many nodes as you can. And tiny nodes which we cannot identify on, in fact, we cannot submit them. They don't have to submit. Only those nodes which we can dissect. So it's up to the surgeon. Usually they send a few nodes at a time, and rest of the fat we submit later on for paraffin section. So the palpable nodes, the larger one, anything above 5 millimeters, just bisect them. Smaller ones submit entirely. Here we can put 2, 3, 4 nodes on one chuck, so it is possible to minimize number of frozen section slides.
Okay, I think I've counted all the questions which came actually until you finished your presentation. Maybe I can take two more and maybe we can stop after that.
Mhm.
There's one question in small tumors where the tumor is present in the biopsy only, but on
Mm.
resection where no residual tumor is seen. How do we stage that tumor? Do we have to review
So
the
it
biopsy and include the same in the resection report, or just write a note as a same?
so it's up to you, but you have to clearly give the message to the surgeon that ideally what we do is review the biopsy. We take the size of the tumor in the biopsy, which may not be the right one, but average size, because these are them small tumors. But definitely these are T1 tumors. So if it is in the biopsy and it is not there afterwards, that means it's usually T1 tumor. Give the whatever size in the biopsy. Now here we cannot comment on depth of invasion or pattern of invasion if the biopsy is really fragmented. So there is some limitation for that. So the best way is we submit entire the tumor bed We say that we don't see tumor in this specimen, and we have gone back and reviewed the biopsy, which shows the tumor. The grade is this, grade of the tumor is this, the size in this biopsy is this much. If possible, comment on pattern of invasion, but many times it may not be possible. And that's it. Better to comment on that in the final report, because every time the surgeon may not go back to the previous biopsy. So it's best to review the previous biopsy if it's available and try to give as much information as possible.
Okay, two quick questions and then we'll stop. How do we measure the third dimension of tumor when the bone is involved?
So when we slice it, you have to go through and through. Basically, we have to slice the tumor with underlying bone through and through, and you can get rough idea. Now here, will it make any difference? This difference, as I said, the core element is the greatest dimension. Other two are non-core. So try to be as accurate as possible, which may not be always possible in head and neck specimen. But when the bone is involved, it automatically becomes T4A. So the tumor size may not even matter, although we have to give the tumor size. Greatest dimension is always important.
Okay, I think the next question we'll take it as the last question. The CAP protocol says extratumoral perineural invasion or PNI and angiolymphatic invasion also count as WPOI 5.
Yes.
Is it irrespective of pattern of invasion?
So if it is present, call it as WPOFI.
Okay,
Especially perineural invasion. Perineural invasion. Lymphovascular invasion hardly we see in squamous cell carcinoma. For some reason, we don't identify them so frequently. But perineural invasion, definitely it is pattern 5.
okay. I think there's something about, I think we need to stop.
I
Right. I
think
think I,
we
I have,
could
I
not add.
have, I have two more slides and it's just a two more announcement for me to make. I'm afraid I can't take any more questions here. Let me
Sorry
share
for
this.
that.
Let me take this share again, this one. Okay. So we've just finished question and answer. So two small announcement. So ladies and gentlemen, next webinar is going to be on Wednesday, 12th February. Again, based on gross examination, frozen section on breast pathology and oncology surgery specimen. So this is the link that is mentioned here. And actually, there have been 2-3 questions regarding whether recordings will be available to everybody or no. So I can state that all the webinars in this series will be recorded and stored on the Royal College of Pathology's website within the International Virtual Resources webpage. And we aim to have the recordings uploaded to the website 2 weeks after each webinar. One more thing is that each attendees will be given a short feedback form, and we do encourage you to please fill the feedback form, which allows us to let us know how we have performed. And it will take less than 2 minutes, and it will be completely anonymous. So we request all of you to please fill the feedback form. And I think in the last, I must thank again Dr. Asawari Patil for spending her time giving her meticulous description of grossing and frozen section assessment. I must also thank Gail Chandrati from the Royal College of Pathologists, who have given us who's actually the backbone for this webinar. And I thank all the attendees who have given time for this attending this webinar. And see you all next week, Wednesday, Indian Standard Time, 7 p.m. and UK time 13:30. I will just add that if you are based outside UK, please check the time difference because it is Greenwich Mean Time 13:30 and Indian Standard Time 7 p.m. next Wednesday. So thank you all again and see you next time. Thank you.
Thank you, Kedar, and bye, guys. Thank you all.